Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball. We've had the absolute privilege of chatting with some amazing Canadian as well as international guests over the past year. While the topics have been broad in range, whether clinical, social, or political, our aims for the podcast continue to remain the same. We hope to inspire discussion, creativity, scholarly research, and career development in all Canadian surgeons. We hope you enjoy our second season as we continue to highlight some incredible guests, deliver detailed masterclass sessions on a myriad of clinical topics, and introduce some fresh new features such as debate and companion formats. We hope you relish the podcast as much as we do.
In this episode, we were honored once again to have another icon of trauma surgery join us. Dr. Ernest E. Moore is the trauma surgeon at the Denver General Hospital. In this episode, we explored Dr. Moore's early insights into the development of trauma surgery and then later acute care surgery as distinct specialties, and how he defined not one but two major surgery journals and had an almost unfathomable research productivity. Finally, we tried to glean some insights from Dr. Moore as to how he thinks surgery will continue to develop in the future, about his thoughts on gun control as a trauma surgeon, and how we might rediscover our passion and joy as surgeons. Sir, we'd like to just start off by talking a little bit about your training pathway. You're certainly not going to be unknown to any of our listeners, but many listeners may not know what your career trajectory was. Where did you grow up and where did you do your training?
Well, I grew up in Pittsburgh, and my father was an old-time family practitioner. And interestingly, despite his hectic schedule, as you can imagine, an old rural general practitioner back at that time, interestingly, of the 6 children, 4 of us became physicians. So the hard work to us looked appealing, and despite his rigorous schedule, we all pursued medicine. So I think our interest in medicine was spurred by my father, and I actually have all my uncles are physicians as well. One of my uncles was Blaylock trained and set up the open heart program at UCLA many years ago. So anyway, I grew up in Pittsburgh, and I went to Allegheny College, a small liberal arts college just north of there. And they had a unique program with the University of Pittsburgh School of Medicine where college students were invited in and actually paid for summer research. And they were trying to recruit regional individuals to go to the University of Pittsburgh and specifically to become interested in academic pursuits. So I was very lucky because I got to work with some real legends in surgery. I started off with Larry Carey, who you may not know, but he was in Vietnam, and he's the one who really characterized the catecholamine response to shock. And then I worked with Dr. Henry Bonson, a cardiac surgeon, and he was really sort of my mentor in medical school. And I spent time with him developing the intra-aortic balloon because he was one of the pioneers of that. And so I had I was very fortunate to be invited into these research labs at my early age, and that sort of cultivated my interest in research.
That's really interesting that you have so many physicians and docs in your family, your extended family, Dr. Moore. It's one of the things that Amir talks about on the podcast not infrequently is his dad was a general surgeon, and I'm curious as an individual who really has no medical professionals in my family really anywhere. How does that inform your sort of view of his job and of medicine in general, and what were some of the pros and some of the cons of growing up in that kind of really rich environment?
Well, I think some of the pros is you got to see some of the rewards of medicine. And I think that one of the things that some of the current generation of physicians, including trauma surgeons, don't recognize is that the gratification of being a physician, no matter what field you're in, is to believe that you've really helped a human being. And I think despite my father's schedule, I mean, as a family practitioner, literally, he had office hours 6 days a week. And the only reason he didn't have office hours on Sundays because we went to church. But I guarantee you, after church, we went in the station wagon with all the kids and made rounds Sunday afternoon. So, I mean, he basically worked 6.5 days a week. Wow. And he loved it. And I think we got to see, the gratification he had despite the very demanding lifestyle. And, we weren't, we weren't, as a family practitioner, he wasn't rewarded financially that much. But I knew that the people in the town respected him. I mean, he was a living legend. He had delivered about 80% of the people in town that we lived in, a small town north of Pittsburgh. And when he walked down the street, it was gratifying for everybody to recognize him and say, "Thank you, Dr. Moore. Thank you, Dr. Moore." And I think that's really, for us, what motivated, I think, all of us to go into medicine.
Wow, that's a remarkable story, and I'm sure it's not unique growing up in that environment for many surgeons and many physicians. But hopefully we'll come back in the podcast and talk about the passion of surgery again. One of the things I wanted to move to, though, is to obviously congratulate you, but in particular to mention to a lot of our listeners that the Denver Health Trauma Center, which is clearly Denver's busiest and what you've been at for many years, was recently renamed the Ernest E. Moore Shock Trauma Center. And clearly that's a tremendous honor. And it's not like you weren't in the top, 3 or 4 or 5 iconic trauma surgeons of all time, but that seems to be just a whole nother level. How was that experience? How was the ceremony? And how do you put that into words? How do you frame it?
That's a good question. I guess embarrassment might be the first way to explain it. In fact, I almost refused to go through with it. I had a discussion with my wife because when it first was presented to me, I thought this would be overwhelmingly embarrassing. But on the other hand, my life's ambition was to establish, an academic trauma center, and in that sense, I sort of reveled in the celebration that I had succeeded at least to what I had aspired to. Sure, there's many more things I could have done, but the celebration was something more than I could ever expect. And I mean, it was sort of like going to your funeral before the time, because all these people came from out of town and said all these things that were grossly embellished, overstated. And, it was a black tie thing, and there was heavy alcohol and celebration. It was just a fun occasion. And looking back, it was an opportunity to sort of be gratified with what we had done.
Well, you deserve every single one of those accolades, and there's no question, despite your humility, that people were underselling, not overselling. So, congratulations! That's amazing. You certainly deserve it. I've seen you give so many talks over the years, like so many of us, and honestly, every single one of them is superb. But one of the ones in particular that stands out, actually, Amir saw it as well. Both of us watched it. Was the interview session you did on the AAST platform, and you talked about in particular, some seminal moments in history with regard to the first real or dedicated trauma service in the United States, and then the evolution towards defining the actual, subspecialty of trauma or injury care and eventually critical care. For our listeners, maybe who might have missed that talk, can you give us some details on what you talked about?
Well, I'm not sure I can remember exactly, but in general, I think that many appreciate, or should at least appreciate, the fact that trauma centers in the United States developed in county hospitals where there was so much trauma that it had to be organized and dealt with. And city hospitals were the environment in which it could be created. And of course, Bill Blaisdell in San Francisco, who died last year, was a legend. And Cook County with Bob Freeark was the other that was apparently developed about the same time. And of course, Adams Cowley at Shock Trauma in Baltimore came along a decade later. But these individuals had vision. They saw a need, and the county hospital felt it was their obligation to serve the public. So that's how trauma centers developed. Regrettably, and I think, again, a note on medicine itself, as you all know, well, at least I can say that in the United States, we've gone from a profession to business. So trauma that used to be done at county hospitals because we wanted to serve the people is now been translated over to major academic centers because it's lucrative and it's more of a business than it is a service to the community.
Yeah, there really has been a significant evolution in it. There's no doubt. How do you reconcile the business side of it with the altruistic non-business side of it? And it's a question probably that seems intuitive to many Americans, but in Canada, of course, we don't really have that system. It's essentially public healthcare with very little carved off at this point to the private side or the money generating side.
Well, I think it's very distressful to watch it evolve into this, and the ability for us to manage our life has been completely removed, and we're now at the mercy of CEOs and boards that have materially no knowledge of medicine and frankly have little interest. Mm-hmm. And it's, I think, just obscene that we run around, even our so-called county hospital, we run around with CEOs making seven figures. And, we're paid very well, I think. I've always said we're paid well, but to see CEOs run around in their fancy cars and paid 3 times what we are to sit over in their office and manage insurance negotiations, to me is despicable. But it's totally changed our priorities in healthcare. And we aren't driven the way we were before by trying to do the best and, using research and education as an opportunity to improve patient care. They're the last priority now, as I'm sure you're aware. And in fact, it's frightening to see how research is just almost been eliminated.
Yeah, it's almost depressing. And I would say that, even in Canada and certainly in Alberta, we're having the same problems. Research is so far down on the list of opportunities, based on funding and the healthcare structure here as well. The reality is the provincial governments really don't care about it at all, and they have a hard time reconciling the link between quality outcomes for patients and efficiency in general and research. And so I think it's a battle everywhere, no doubt. Speaking of research, if any of our listeners, put you into PubMed, the response in terms of volume of work you've produced and been involved with over your career is almost unfathomable. I'm curious, maybe threefold. What are some of the biggest contributions that you've made that you feel the most proud of? Because oftentimes I think we both know that maybe those are different from the outside perception of some of the amazing work that someone's done. I'm also curious how you've been so productive for such a sustained length of time. Again, it's darn close to unique, and it's something that I try and emulate selfishly, but you seem to do it flawlessly over a long period of time. Those are the first two questions.
Well, I wouldn't say that my achievements are that remarkable, but I would say that anything I've done academically, I would say should be credited to my mentors, and they're the ones that really showed me the pathway. And in terms of the research that we've done in trauma, one of my mentors was Dr. Ben Eisman, who was the first academic chief at the Denver General and hired me. And he was a remarkable individual. And when I first started, I remember I sat down with him and he said, "Well, I'm hiring you because I want you to develop a trauma center like Trunky's done at San Francisco General." And I said, "Well, okay, that's a great idea." And so he took me from right out of surgical residency to become a director of trauma. And then he said, and the greatest advice, he said, if you want to be successful in research, it's fairly simple. You go to M&M's every week, and you write down the recurrent problems and the ones that people don't know the answers to. Oh. And then you sit back and you go review the literatures available and see what's been done and try to come up with some questions or so-called knowledge gaps, we call them now, to address. And that was very shrewd advice to me. The very first thing I noticed when I started as a junior attending was how many people died from liver injuries in the ICU after we got out of the operating room and thought we won the battle. And of course, it was coagulopathy. And so that really was the first area of academic interest I had. And it taught me that I couldn't stick with one area of research, that I had to keep looking at the next uncharted arena to begin to do research. And so shortly after coagulopathy, we got into multiple organ failure, which of course Dr. Eisman in 1975 was credited with coining the syndrome. But we took advantage of his inspiring work and developed basically a research program around that. And ultimately that led into various evolutions. Remember, we developed the multiple organ failure score and began to look at neutrophil priming and the second hit and so on. And at one point with our NIH grants, it sort of looked like we'd run out of gas, and then stumbled on the idea of linking the gut to the lung and started to look at what was in mesenteric lymph. And so every time we turned the corner, we looked for new areas that we thought need to be explored.
Dr. Moore, in addition to all the achievements we've talked about, one of the other things certainly that you've been the editor-in-chief of for quite a while is the Journal of Trauma and Acute Care Surgery, and then of course you've certainly had your fingerprints and guidance over the World Journal of Emergency Surgery and the WSUES in general. How how do you frame those editorships, and in particular for the Journal of Trauma and Acute Care Surgery? How's that impacted your career and your practice, and what's your sense overall of that pretty incredible experience?
Well, again, I was lucky to be at the right time, the right place. I did my surgical training at the University of Vermont, and that's where Dr. John Davis was the chairman of surgery. In fact, he's the one that converted me to do trauma surgery, because under the initial guidance of Dr. Bonson at Pittsburgh, I was planning to be a cardiac surgeon. But when I did training under Dr. Davis, he made it so intriguing that I couldn't resist. But doing my training at Vermont, I was lucky to they asked by Dr. Davis to do the abstract section for the journal. So, I mean, literally as a second-year resident, I was reviewing papers in the annals and writing in the Journal of Trauma, summarizing research, and that really taught me a little about journalism. And then, of course, as it went on, Dr. Davis turned the reins over to Dr. Pruitt, who is also a long-term mentor of mine and a friend. And so that sort of led naturally into my interest in the journal, in taking on some of the editorial duties. The World Society is an interesting story in itself. When I developed the trauma center at the Denver General, one of my major themes was that trauma surgeons need to be broad-based and needed to do vascular, thoracic, complex, abdominal, and promoted that by keeping a small staff and rotating all the cases and double scrubbing and so on. As time went on, the Journal of Trauma seemed to be drifting more towards critical care, and I kept at the various board meetings, and I was in various committees, kept saying, we need to diversify a little bit. We need to get in of our trauma mission, because frankly, someone's sick, they don't call the specialist, they call the trauma surgeon. Well, there's a guy in Italy, Fausto Catino, who heard me talk about this. And just out of the blue one day, I remember I stumbled out of the operating room, and someone said to me, "Hey, there's a guy from Italy who wants to talk to you on the phone." So I got on, this guy introduced himself. I didn't have a clue who he was, and I didn't think he had a clue who I was. And he said, "Hey, I got an idea. I think we should start a new journal focusing on emergency surgery. And I've heard you talk, and I know trauma's linked to it." And he said, "How would you like to start a new journal?" I said, "Wow, that's interesting." And he said, "Yeah, I'll pay you and your wife to come to Bologna next week, and I have a date with a lawyer. We're going to set up and develop this journal, and I'll pay your trip, and we'll spend the week here, and I'll introduce you to Italy, and we'll travel around together." And I went home and talked to my wife, and she said, "Geez, who is this crazy guy? He's worse than you." And so we signed up and went, and that was it.
That's awesome.
It was unbelievable. So that's how the World Journal of Emergency Surgery started. And it was largely because I couldn't get traction with the AAST to get interested in that arena.
Huh. Oh, that's very interesting. Almost independent of the journal, but certainly related, you were one of the very early supporters that I remember talking with passion about the conceptual framework of what eventually became acute care surgery as a full subspecialty. And of course, there was other folks in that conversation with you as well. But how did you see it as the future so early? And in particular, where do you think it goes from here?
Well, the concept of integrating emergency surgery really came because, again, of the experience at the county hospital, where the trauma surgeon was the surgeon who did everything that no one else could or would do. And so my vision was that to maintain credibility of the discipline, that we needed to keep up our skills and present ourselves as sort of a, quote, master surgeon, that when there's a problem no one else could do, we'd do it. And I think on the one sense, acute care surgery has salvaged trauma surgery as a viable discipline. On the other, it has, I think, lowered the reputation of trauma surgeons, because many trauma surgeons in the United States don't do much high-level operative work. And so it's been a two-edged sword, to say the least.
Dr. Moore, people have these phrases, right? Like, so-and-so literally wrote the textbook on such and such a topic. But in your case, we can literally say you wrote the textbook on trauma. And Dr. Ball and I were looking at that, a copy of the textbook just before the call, and just admiring that fact. Can you tell us how you got involved in writing the textbook? And how do you think about the importance of such comprehensive Bible-style textbooks in 2020?
Well, the story behind the book is interesting. I first edited a book with Dr. Eisman called Critical Decisions in Trauma. I'm sure you guys don't have a clue what that was, but it was a book of algorithms. So we took every trauma problem and made it in an algorithm, and then explained in the narrative of why those decisions were made. It's really the template of what's done by the Western Trauma Association, and it came really from that project. Well, as a result of that book, which was unexpectedly very successful in trauma, and it makes sort of some sense at this point, because in the middle of the night, you're confronted with a bullet through the carotid, and what do you do? Do you shunt? What do you do if it's 3 hours old, and so on? And this book would go through all that decision tree. Well, based on the fact that I had, gained some reputation in editing, and I give that complete credit to Dr. Eisman, because he made me co-editor in his book, but I guarantee he did 95% of the work. I came to the American College in Atlanta, and I had a message at my hotel room that somebody from McGraw-Hill wanted to talk to me about editing a book. I said, wow, that's interesting. And so I got on the phone, and this person said, I'd like to meet you while you're at the college and talk about doing a big textbook in trauma. Because, the one that's out now, which Rutherford is doing, and Bob Rutherford was at our institution as a vascular surgeon then, is really not selling well, and most of the authors are not trauma surgeons. And I said, sure. So she said, make me a list of the chapters and the authors you would select. So fortunately, I had a list of all the SST members, and I met that week, and I went through this thing. And she was rather non-committal. It sounded interesting. And then I didn't hear anything for about 2 weeks, and then she called me back, and she said, I got a proposition for you. We're interested in you being editor, but we interviewed another guy named Ken Maddox from Houston. Do you know him at all? I said, yeah, I know him. And at that point, I knew him more by reputation than personally. He said, if we sat down and compared your notes, they're almost identical. He's picked the same topics, the same authors. He's got the same idea you do. Do you think there's any possible way you guys could work together? Because we think as a team, you'd be stronger than independently. And I instantly said, sure. Of course, Ken was older than me and had a much bigger reputation in trauma I ever had. And I said, sure, why wouldn't I want to partner with this guy? So that's how the book evolved, because they called Ken and offered to him, and then they said, "Can we get you guys together?" And the next week, he and I were on a conference call together, and then Ken said, "I have a junior guy you probably know, Dave Feliciano." I said, "Yeah. Actually, Dave and I were pretty good friends at that point because we were sort of growing up together in the academic arena." He says, "How about if we add him on and three of us will do it?" I said, "Great." So that's how it started. And I could tell you some amusing stories about that, which again, I probably shouldn't. But if you talk about two personalities who are journalistically diametrically opposed, you would find David Feliciano and Ken Maddox. Ken would just sit down and wrap things off and, would give a second thought. He'd just ramble on. Dave Feliciano, when he wrote something, it would take him a month. He was so meticulous. He wanted to look up every little detail. So I was sort of the arbitrator between these two, fighting with each other constantly with every edition of this book. We, of course, had been long-term good friends. It was amusing watching the different approaches to journalism that ultimately led to this product.
That's such a great story, and I can certainly see you in the middle of both those gents for sure.
Dr. Moore, I did want to touch on a slightly different topic, which is you took the unusual step of, or maybe it's not that unusual, but and maybe you can talk about whether it's unusual or not, but you took the step of actually speaking out against assault rifles, and in fact, there's a well publicized article about you actually disagreeing with your brother about whether assault rifles should be banned or not. What compelled you to kind of speak out about assault rifles, and how do you see surgeons participating in this very national public debate around gun control in the U.S.?
Well, that's a politically sensitive topic, but let me put that frame a little bit. I'm an avid hunter. I grew up, in Western Pennsylvania, and the only time the boys and I got to spend time with my father was hunting season. So we all became very avid hunters, and I remain an avid hunter. Elk hunting is one of my favorite passions, despite my wife's disapproval. But I am a very avid hunter, but I did witness, as you may know, Columbine. And I was struck by the fact that there's so many innocent high school kids just mowed down in this devastating event. And then that was further supported by the Aurora movie theater shooting. And it just, to me, was so unconscionable that we would arm crazy people with these devices that could go out and randomly kill innocent people. Not to say that gun violence in the United States and the ravages, are deserving, but I always say when the residents say, so-and-so got shot, and I said, you play with fire, you get burnt. So to some degree, some of the violence we see with guns is brought about by individuals that they've made that decision. But these poor kids that sit in high school and have someone come in and just mow them down at their desk, to me, was unacceptable. And I, despite my joy of hunting, and I don't necessarily enjoy killing animals, but I certainly enjoy hunting them, I didn't see rationale for having an assault rifle. I just didn't see the purpose of it. It's a military device, as you know, and it's designed to kill as many people as possible in a short time period. And so it just didn't seem to be an instrument that should be put in the hands of people that can't make rational decisions.
One of the things, and we keep going back to this interview because I reread it last night and just found it moving at places. One of the things that I really enjoyed that you spoke about in that interview with the AAST is sort of like the fact that there's this rhetoric around limiting work hours has perhaps kind of dampened the conversation around loving surgery and the fact that actually having a passion for surgery is what makes your career fulfilling. And we sort of touched on it a bit already in the interview, but how do you think that the conversation has changed, or how do you think the work hours has sort of changed that conversation, and how does that current reality concern you, and what do you think we can do about it?
Well, I think there are two things that have hurt our discipline. I've alluded to one is that we have given up complex surgery so that we now view a laparoscopic cholecystectomy as a challenging operation, which has led to, our basic skills have deteriorated to a point of being embarrassing at times. The second thing, though, that hurt us, I think, as a discipline is this concept of shift work. And perhaps best epitomized in trauma. You can't select when someone's going to have a severe injury, and you simply can't treat them by turning the light switch off and on. I took call just 2 nights ago, and a guy was shot 6 times with large caliber bullets. I've been back to the operating room with him every day for 3 days. And, the first time was 3 o'clock in the morning. The next time was 2 o'clock in the afternoon. And I just finished him 2 hours ago. And that's the way it's got to be. You got to be committed to those patients, and you got to put everything else away and take care of those patients. And I missed, research meetings. I missed conference calls. But when this patient needed care, I took him to the operating room and led the team through. And that's a rarity here. I often listen to stories at M&M's, which just drives me crazy, and complications where someone will have 5 different attending surgeons and no one knows who's responsible. Of course, no one wants to take the blame. And my constant rebuttal to that is, why don't you guys take care of these patients? You put a knife on them, you own them. Why would someone else take someone back to the operating room for open the abdomen or whatever it is when you're the surgeon? And these people, the new generation, look like, I'm deranged. Why would you do that? And they walk out of here, routinely at 4 in the afternoon and think that's a full day's work. And to me, that has destroyed our reputation as trauma surgeons who not only can A, take care of everything, but B, are always available to take care of our patients. And most regrettably, I think the new generation, and I'm speaking generically, there are clearly exceptions, but the new generation is missing that gratification of taking care of that patient. What I started with what we respected out of my father. When you have, and we all have, these miraculous saves, everyone in the hospital knows you. The nurses know you. The family knows you. The people that bring meals around know you. Just the gratification of doing something beyond what's expected is lost now, because with this shift work, no one knows who the attending is. And when someone gets in trouble in the middle of the night, they call who's on call, not the surgeon who did the original operation. So it really has, in my sense, has significantly robbed us of the gratification of why we do all this. So that's my concern.
Yeah, I couldn't agree anymore, Dr. Moore. Of course, as the scenario or as the case gets more and more complicated, there's so many details that are lost in translation when you have those sign overs, changeovers, shift work, whatever the terminology you'd like to use is. It becomes scary on occasion, and I don't necessarily think. I mean, you might disagree with this, but I don't necessarily think that patients and society and the public at large understand that structure and understand that the risk and the risk to, them, but to quality and efficiency in general, that comes with that structure really exists. I almost feel like as a system, if that's your system and it's a shift in, shift out structure or framework, we're not being honest or at least forthright with the patients in terms of that level of risk that you're touching on.
Well, absolutely. The press has made it such that a patient's family would rather see, a shaven, bright-eyed physician in the morning rather than someone dragging in with unshaven and blood all over them. And they don't recognize the difference. And in fact, if anything, they believe that we all need 12 hours of sleep at night and we shouldn't work more than 30 hours a week. And there isn't anything such as stress because that limits our decision making. And I totally disagree with that framework.
Yeah, there's no doubt there's some giant problems that attach to that.
Well, I guarantee you did your Ripple today, and I guarantee you wouldn't dream if you ended up having a biliary or pancreatic leak to have one of your partners taking care of that.
No, you're exactly right.
You wouldn't sleep with it. You wouldn't live with it.
Dr. Moore, in closing, I wanted to maybe bring us full circle. You started this amazing conversation with us talking about growing up in your family and with your dad. You have, and I think you touched on it very briefly, you have a couple of great sons, and I can tell, the audience, having talked to one at length and the other one a little bit, they're really good guys. Like, you and your wife have done a tremendous job, and I know you know that. I'm curious with all the stuff we've talked about, your clinical volumes, your administrative burden, and of course your research side of things, in addition to all the things I don't know about that you do on a daily basis. How did you balance and manage your family? Because I think lots of us struggle with that equation for sure. Well,
I'd give 100% of the credit to my wife for anything good that's happened in our family. I can assure you. You probably know my wife. She's an internist, and she's very quiet and reserved person. But as all my friends would say, I don't mind annoying you, but I do not want to cross paths with your wife. They're deadly afraid of her. So she's kept me honest. And I think that fundamentally, when you begin your career, you need to decide what your priorities are. And inculcated in me, and certainly reinforced by my wife, was that the family is your number one priority. And, you're reminded about it every day. You go in rounds and you talk about a Dr. Eisman, and the medical students and residents, their eyes are glazed over. They don't have a clue who you're talking about. And here, in his time, he was a literally walking legend. And 3 years after he dies, no one knows who he is. And so I think that you have to be careful of what you think you're accomplishing and understand that really your legacy is your family. And in that sense, the priorities as you go through life, I think, become important. And so I would certainly give my wife credit for all the academic achievements of our boys. And, Hunter is a transplant fellow and Peter is a pulmonary fellow, and both of them are going to be full-time academic when they finish. So we're proud of them, and we're proud that they've pursued those careers because I think they recognize and they see all their friends who have made much more money than they're ever going to make, and realize they could be making money in other professions, but look to the gratification of what medicine presents. Now, again, as I went through my challenging years, and certainly when I was in the 40s and 50s, the academic challenges and demands were tremendous. But I I set the priorities, and one of the things I'm glad that I did, and the boys remark about this when we have a few beers, is that I committed myself to their activities and what I focused on, because I couldn't compete with my wife in the academic arena with their education, was their sports. And I can guarantee you that unless someone's dying in the operating room, I never missed a hockey game. I never missed a lacrosse game of my two boys throughout their life. And they acknowledged that later, that they knew I'd be in the stands every game. And they knew no matter what the outcome, that I was there to support them. And I think that, as I always say, my favorite quote, I'm not sure I can take any credit for it, is that you should, you cannot work hard unless you play hard. And you got to remember that your family is your number one priority. And that's the life I've tried to live. It's certainly not been perfect all the time, but I still believe that's important. And people have asked, why do I still go to work? I should have been retired 15 years ago. I certainly could have afforded it, frankly. But I can't wait to wake up and come work, whether it's a research lab or taking trauma call. I can't imagine giving it up until the point in which I think that physically or mentally I shouldn't be doing it. And it's just a way of life.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.